So I'm very excited to have to introduce our three panelists for today's discussion. First, we have Dr. Samuel Uaje. He's a senior research ethics advisor with the Canadian Institutes of Health Research, or CIHR. His research specializes in bioethics and global health ethics, and he's an independent ethics expert for the European Commission. He was previously an ethics consultant to the Bill and Melinda Gates Foundation on health research and interventions in sub-Saharan Africa and Asia. So thanks for being here today, Samuel. Next, we have Chris Carter. Hi, Chris. Chris is a longtime patient partner with NL Support. She has an MEd in post-secondary education from Memorial University and is a community representative on the Health Research Ethics Board, and therefore she's able to provide a very valuable perspective on the ethics of patient engagement in research. She also sits on a variety of national committees, including the Citizens Advisory Committee of CIHR, as well as the StatsCan Expert Advisory Committee on Population Health Statistics. And last but not least, we have Dr. Holly Etchegary, who is an Associate Professor of Epidemiology at Memorial University, as well as NL Support's Academic Patient Engagement Lead. Her research interests include genetic health services and new genomic technologies, as well as the psychosocial effects and ethical implications of genetic risk. She has extensive experience in conducting on and advising on patient-oriented research and public engagement. So with that, we'll now get into the exciting part. So we're going to start today's session with a short presentation from Dr. Uaje. So he's going to discuss CIHR's ethics guidance for developing partnerships with patients and researchers, as well as some emerging issues in ethics. So I have no doubt that his presentation will spark some interesting discussion. And then with the time that we have left, we will discuss some commonly asked questions that our panelists have received regarding the ethics of patient engagement in health research. And I think this will give our panelists, as well as our participants here, a chance to provide their unique perspectives on the topic. So with that, I'll pass it along to you, Samuel, and I'll stop sharing my screen.
Good morning, good afternoon, and good evening, wherever you're joining us from. And I hope you're having a nice and sunny day as we're having it here in Ottawa, where I am presenting. And I also like to recognize the first settlers in this land. I'm unable to do the conventional acknowledgement, but I would like to recognize those who settled on this land first, Indigenous people on this land. So today I am presenting a review, basically a review of the CIHR ethics guidance for developing partnership with patients and researchers. Just a caption of how I'm going to proceed. First, I would just do a brief introduction of that ethics guidance, and also kind of review why we think ethics is important and where we are putting ethics somewhere in the front corner. And then I would go on to highlight the key ethics elements, the core aspects of those elements, and also the kind of concerns that we are looking to address using these core ethics elements. And then I will end by highlighting some emerging ethical issues within this space. So the aim of the guidance, so this is not to put it, it's not a regulatory document. For example, we have the TCPS2 that I believe many of us will be familiar with, and there are a number of other ethics guidance documents out there that are regulatory and have the strong force of higher regulation. This is not a regulatory document, it is a guidance document, which is being put out there as something that can help to guide researchers and patients who are entering into that partnership when it comes to the research space. And it's here to help in the process of that patient-engaged partnership. So putting in patients who have traditionally been participants in research, but now we are moving forward to a space where we are collaborators rather than having research subject and research, maybe research object, put it that way, the researcher and the subject of research. And secondly, also is in recognition of the living and the lived experiences of patients when it comes to research. So it's not simply about what the researchers think and the kind of hypotheses that they make and they want to make the analysis based on, but also the validation. This becomes a validation of the living and lived experience of patients when they come on board. And also the intention of this is to contribute to the ongoing conversation. This is it's an emerging field, if you want, and it's a new area that we are moving into to make more excellent research. So it is not a final word, it's not a final statement on the ethics of how patient engagement should happen or patient partnership engagement should happen, but it's rather contributing to that process. And we're hoping during this conversation, we'll also gain new insights, perhaps get new direction from people who may have newer experiences or have delved into new dimensions of patient engagement in research. And the guidance is not just about the do's and the don'ts. So it moves beyond that and suggests pathways to improve this partnership. And I would just like to make it, just for some clarification, if you see where the point of the engagement is moving from, if you look at the screen, moving from the right to the left. Back in the day, it used to be the researcher holding the lens and looking at everybody else and try to imagine and determine where we should go or where things are going. But now we're moving forward to the left, where we have the researcher and, if you wish, the patient representation, somebody who has that the experience of the situation that the researcher is researching, coming together, sitting down together, and together looking through that microscopic lens to determine what the situation is. And in this space, we are looking at the ethical issues relating to this collaboration, the ethical issues relating to the engagement between the patient partner and the researcher, and not the engagement between the researcher and the participants who are inside that lens. So it's about the green and the blue and the gray that you see there. That is what those are the ethical issues that we are reviewing at this point. And so in the course of this conversation, we'll be making reference to patients, and this will not be patient as not the research participants, but the patients would be here referring to the people who have the personal experience living with any illness or a condition that is being researched, or caregivers of those people. And this would be the people that would be partnering with the research, with the researcher. It may well be that at some point they could be part of the research participation, but in this space, we are looking at their collaboration, their engagement as partners with the researcher, rather than as simply as participants, subject of the research. And the engagement here is the process of meaningfully engaging this representation of the patient representation in the governance of research and in the conduct of research. So it's beyond simply just come and be part of the research, but here is come and oversee, come and provide oversight, and come and give reviews and in the light of their own experiences. So here is primarily recognizing the experiences. So why is patient engagement important when it comes to research? And there are a lot more reasons why we would want to engage with patients when it comes to research, or why we would want to partner with patients when it comes to research. And part of it is to improve health, broadly speaking, because if the aim of research is to enhance health, well, then that is what we're about, is to hear the input from the patient partners. And there's also the dimension of the access. So we cannot improve health if we don't have access to the healthcare system. Because those whose health need to be improved need to be able to have access to the system to have the health improved. And also not just having access to the system, but getting the right kind of treatment. And sometimes treatment can be good, but it may not just be right for the person who comes through and who is being administered that treatment. And giving an active and informed voice to the patient's representation in that space. So if this is what the experiences of the patients are, the research, the output of that research needs to be able to address the experiences rather than simply what the research community concludes as good as it may be, but sometimes it has to specifically address the experience of the patient. And there's also the point of quality and also making contribution to the cost of the cost effectiveness of the healthcare system. So there are many more, but these are just some of the aims that we look to address when we engage patients partnership in research. And some more key consideration, especially in our space, given the strong reliance and engagement that we have with Indigenous people in Canada, there is the specific consideration for Indigenous rights when it comes to patient research. And here it's in the light of giving that space for respecting the various, the many different ways of knowing. So there is epistemological lens of analytic of analytics when it comes to knowledge and methodology. And sometimes the more established, I put in quotes, the more established methodologies take precedent. And we forget that there are other ways that we can know, and there are other ways that we can learn. And when we collaborate in the space, for example, there could be the Indigenous ways of knowing that we would need to respect, we would need to figure out how that works and how that actually informs our research. And I think for a good reference, we can find that with there's a cultural responsiveness framework by the Federation of Saskatchewan Indian Nations. And I think that can speak to the kind of direction that we go when we engage with Indigenous peoples in the context of research partnership, the patient partnership in research. So I'll move forward to the next question as well. Why ethics? So here I would also like to distinguish that there are two dimensions. There is the strategy for patient-oriented research, which kind of determines how this collaboration should be done. What are the kind of steps that need to be taken? That is on the one side. On the second side, and which is what is our interest here today, is looking at the ethical dimensions. Some of the kind of moral issues that come up when we begin to engage in these various stages. And this is where ethics becomes significant. And why do we need to engage ethics in this space? For one, this can help to ground research in a deeper way. So much of the time, researchers can perceive issues, can see issues, can analyze issues, but in order to get into the deeper experience of the issues, we need to sometimes move away from the simple analytics and actually allow room for the subjective experiences of the patient, of those who are being researched. And that way, we get to understand the situation holistically rather than simply by analysis. We get to understand beyond what we can see and beyond what we can touch and analyze to what we can perceive. And these are all part of it. And there's also the point of creating that cultural safety, respect, and appropriateness. Now, we can have, and there are actually examples of very excellent research out there that are not culturally sensitive or culturally safe or respectful. And much of the time, those excellent research end up not being assimilated because by the population it's meant to serve, because the population don't respect it, because it does not respect their values, or it does not consider their cultural safety. And so they don't engage even in the wonderful output of those. And then the point of ethics here is also to legitimize research. However good a research is for a community or to a community of patients, if that community does not recognize it as legitimate, either the output or the process of that output as legitimate, then it doesn't work for them because they are not going to use it, they're not going to accept it, and then we end up not addressing what we set up to. So the engagement can help looking at from the ethical space. And then finally, all this can only be achieved if we're able to create that respectful space for dialogue. And it is in creating that space for dialogue that we are actually considering the patient engagement or collaboration in the research, where the patient and the researcher collaborate and try to figure out the various steps that can be taken to address the point. So the voices are part of the process, not simply part of the analysis. So much of the time, the voices of the patients or the research are only seen in the analysis, but not in the process, in the research process itself. And this is why ethics. And overall, the point of this ethics of the patient engagement in the research process is to foster trust. So trust is central. It's when we have trust, then we can begin to address some of these other issues that I have been talking about. So when that trust is built, then we can move on to actually having a better research outcome. The research process can be legitimized. Research process can be, the research output can be acceptable to the community of those being researched. And I will move on to the 4 considerations for engagement with for partnership with patients when it comes to research. And on the first part, we are looking at mutual respect, and I did elaborate on this a little bit earlier. So the mutual respect for the different ways of knowing and of interacting. So there is not just this one way of knowing things, perhaps by analysis or by the analytic, following the analytic tradition. There are also different research disciplines, and there are also many ways we can engage the living and the lived experiences. And these can be as subjective as they may be, and in traditional research, so much of the time subjective views may not count, or perhaps the living or the lived experience of someone just by the virtue of having a lived experience may not count. But in this space, we take this also as important, because sometimes this can help to allay some of the conscious or unconscious biases. So much of the time when we do the analysis, there could be some unconscious biases that even the researchers may not be aware of. But when we have that collaborative engagement with the patient, then we're able to learn from their own subjective experiences that can actually inform or can make us even aware of the unconscious biases that we have, or can help to actually address the conscious biases that we may have when it comes to analyzing the data that we collect for the research. And in the background of that, there's going to be that humility, but also there's going to be respect for the patient perspective, but also the humility of the researcher to accept this new way of knowing and this kind of new direction that we take in research. Then we have the equitable participation and rights. So if you are researching a group of a community of patients, a group of people, as a researcher, we are hoping that the end product is meant to help this group of patients to get out of the situation that they may be in. And what best way is there to grant this group of participants or the community of patients that right to also be part of the process that would result in what should be of help to their own community. So they have the right to shape the research that is intended for their own benefit, but also to be part of the research activities and the outcome. When they're part of it, it makes it credible at the end of the day. So not simply credible to the research community, but also credible to the community that is going to use the outcome, because that is where we are aiming at. The aim is not simply for the research community, but for the benefit of the community being researched. And then there's also the point of reciprocity and the shared commitment in whatever the research outcome would be. And the commitment here would be in terms of producing something. The research process and the outcome should come up with something that actually is relevant to the health of the patients that we talked about. And in the process, it means that there is also that need to recognize, but also to support the patients in emphasizing and in also emphasizing their own perspective and their own experiences in the process. And then finally, in terms of personal integrity, and I think this is where one of the challenges can come. There's that honesty and humility and honesty in fulfilling the promises that are made. Often patients, or traditionally when participants come into research, there are lots of promises that they hear about how this research is going to help their community, and usually that's the motivation to participate in research. But then there's the other end of it, of how to keep to these promises. There's going to be that honesty. And this is where the personal integrity comes in as an ethical, as a key ethics consideration. But there's also the question about managing conflict of interest, and conflict of interest being a situation where the researcher, either in their own personal space or in their professional space, may have other engagements that may raise concern for the community being researched, or in terms of the whole, the topic being researched, and how the participants or the patient's representative perceive those in terms of their own lived experiences. And when this can be granted, when this can be managed, can be addressed, then it helps the process of collaboration, and it helps to actually effectively engage patients when it comes to producing research outcomes. So these, what I've mentioned earlier, those are the ethical considerations that we have if you want to see them as some of the kind of ethical commitments that we are hoping to make. But what are those commitments meant to address? They are meant to address a number of other core issues, core ethical issues. And this is what you can see on the screen right now. I have mentioned 4. There would be perhaps a good number of other things, other ethical issues that could be addressed, but I will just make reference to this 4. And first, we can see here legitimation, tokenism, levels of engagement, and representation. So often research can be good, research can be excellent, but it could lack legitimacy. And this is where we need to engage with those who would legitimize the research, who would say, this is our situation, this is what affects us, and this is how we would need it to be addressed. And if the research actually addresses those concerns, then it becomes legitimate. If it doesn't, then it is not. And in terms of the tokenism, and this could be a kind of common practice, not common practice, but something that we would know happens a lot in the research space, where sometimes participants may be engaged, just say, yes, we also covered this group and we covered that group and we've covered everything. But then whatever outcome or the input of those groups that we get, we don't really take them seriously in the analysis that and the output that we have. And that would be tokenism. But in this space, the point here is whatever the input is from the community or from the patient community that we get becomes a crucial aspect of the research process. Not something that we hear and we report on, but becomes a crucial aspect that shapes the entire research. Then it becomes non-talk. So we're addressing the issue of tokenism. But also there's the question of representation. And that can also be a large part of addressing the tokenism. So if we really need to address an issue within a patient community, for example, a tokenism can be just picking anybody from this group who can just come and sit on the table and say whatever you think they will want to say and perhaps put it forward. But in moving forward to avoiding tokenism is also to actually pick up some crucial members of those communities. For example, picking the community leaders or respected members of that patient community whose point of view can actually be largely representative or largely respected by their own patient community as representing their own voices. And that can help avoid that. And on the question of conflict of interest, like I've touched on, the point here would be using those core ethics considerations that I put forward earlier to address it, to ensure that a transparent management of any perceived conflict of interest. For example, there will always be conflict of interest in many different respects, but much of the time, the problem is not the perceived conflict of interest, but much of it is about how that conflict of interest or the perceived interest is managed. And often when that is managed transparently with the involvement of everybody and with the understanding of that, then the situation can easily be resolved. But also there's the third dimension of it is there's also the cultural recognition when it comes to conflict of interest. There could be something that may be perceived in one cultural space as conflict, whereas in another cultural space, that may not be perceived as conflict. But when there's that collaboration, there's that respectful dialogue, and there's that understanding, not to be dismissive of what the other a group may find as conflict or may consider as conflict. But having that dialogue that can be respected, and then we have a transparent process where we manage the conflict, that becomes helpful. And the third concern that we try to address with this ethics consideration are the power dynamic. We all know that there's always the power dynamic, where most of the time the researcher has the power when it comes to dealing with research participants, research subject. And that can be easily be translated to that collaborative partnership with patient partners, because the patient partners are coming from that weaker position that they've always been as patients or as subjects of research. And now coming to sit on the same table with the researcher, the power imbalances could remain. But if we look at that, the core key ethics consideration that we put forward, and we actually take those seriously, then that can help to balance, to create that balance of power, where the patient partner also begins to gain a more respectable voice on the table with the researcher. And finally, we have a situation where we try to address the systemic and structural barriers in the research space. And here we'll be looking at policies, practices, and procedures that could result in some people being pushed further down the ladder of equality, especially when it comes to access in health and to healthcare facilities. And this can be perpetuated by research or by the outcomes of research. But when we allow that equitable space and grant the patient participants the right to also voice their own experiences and living experiences, then we begin to delve into that space, to begin to address the issues that are, first of all, part of the policies that perpetuate the inequities that we see around society, that creep their way into research, and research outcomes that end up re-perpetuating the cycle of inequity instead of addressing it. So much of what I have been talking are kind of like the conceptual frame of reference for partnerships, for creating partnership between patients and researchers. Now, the second part of the guidance document, which I would not have time to delve in, but I'll just highlight that there's a second part that provides some kind of a practical guidance on how researchers and patient participants can collaborate in the various stages of the research life cycle. And here we have 10 of them, for example, starting from priority setting and planning of the research project, developing of the proposal, going down to project oversight, recruitment, knowledge exchange, and evaluation and quality assurance. And these are specified. If you have time to go through that document, you will see there are individual specifications on those. These are suggestions. They are not rubber stamped on this is exactly what you must do, but these are kind of guiding suggestions on the kind of things to do to ensure that the whole process, the activities in that research process are ethical, and the activities of the collaboration are ethical, and that could produce results that are acceptable and legitimate. So finally, I'll go to highlight a few what I'll call emerging issues in this space. Like I said earlier, the guidance document that I've made reference to does not cover everything, and it's not a final document. It's something that is still in process, because even the experience that we are and the space that we're going to, we are still exploring. There are a lot of emerging issues that we may need to look at. And taking from the indigenous recognition, I also like to also point in the direction of the racialized minority groups. And thanks, but no thanks to COVID-19, we know from the data that we have seen that racialized minority groups have been inadvertently affected in terms of infection and death, or perhaps much of the suffering that we accord to COVID-19, and that's kind of can be generalized to much of the health experience of racialized groups. So here is also, when we come to that patient engagement, it's also to consider the perspectives and experiences of the minority groups, especially when we look at the racialized Black, Hispanics, and other racialized minority groups. And also to appreciate, there's the second dimension of appreciating the divergent cultural underpinnings of race. So race is not simply about just the physical appearance of someone, but there's also a cultural underpinning to race that we can acknowledge, especially when it comes to engagement in the research space, and the kind of voice that would need to hear to appreciate that, and also to identify and recognize the nature of systemic racism in the research ecosystem which exists, and actively finding ways to redress that in and through the research process. That could be one thing. And the next one here is looking at some findings, some published findings by Felice, Couture, and Roy, where they review the question of equality and equity in compensation when it comes to patient engagement. So usually, researchers could have the funds, and if they're inviting other researchers to collaborate with them, they have established standards of how to compensate these other researchers. But there is the question about, there's an existing obstacle in the interpretation of fairness when it comes to compensating patient partners. And the standard practice may push towards giving compensation that may be similar to compensating subject of research, but here we're looking at partners of research. And this finding, the recommendation of those who put out this publication actually is that fairness may not simply be how we provide compensation to patient as research subject, but making exception to patient partners who are more on the collaborative space, and to provide them with a compensation that should be more appreciable of the kind of time and the input that they provide, and recognize that their input is actually a critical part of the research, and based on that, make compensation accordingly. And then there's also the finding about establishing a shared vision about the goals of patient partnership. So part of the danger that we could be entering as we move into this space is the tendency to make every research automatically become a patient engaged research. So the point that number 3 makes is, rather than simply just going into patient partnership on every research that is being conducted, the point is to always stop for a second and ask, why should we, or why are we getting into patient partnership in this research? So there is a need to always know exactly, to specify the reasons why we are getting into patient partnership. And so that even when we get into partnership, the patient partners that come on board know exactly why their engagement is happening. They know exactly what they are contributing and where their contribution is going to, because there is that clarity and there's a respectful clarity of roles in that space. And if we don't have that, then we can end up in that cycle of tokenism, where every research simply just has to get patient partners, and then we have fulfilled the duty to involve patient partners, and that's it. But when we begin to engage, knowing specifically the reason why we engage, then we ensure meaningful engagement. That engagement becomes meaningful because it has a purpose, it has an end. But also it helps us to avoid instrumentalization. So we're not simply using patient partners just to make sure that we fulfill that research requirement. And also it helps the researchers' role even to make it easier. Because sometimes there are some undue expectations that even research participants or the wider community may have on researchers who are performing research. And we can see from, for example, taking at COVID, how those who are researching on COVID vaccine, for example, may have been on the edges, you have to produce vaccine that can help everyone get back on board. But if the patients have an insight into what is happening on the inside, then they understand even the situation that the researchers are placed in. And they are able to be perhaps even patient enough to work with the researchers through the whole process until the finding. And if that finding takes longer or shorter, it helps, because then the pressure is even much lower on the researcher's side, as well as also not simply tokenizing the research, the patient community. So I will stop here. Thank you very much.
Thank you, Samuel. You've raised some, I think very relevant and considerations when we are talking about patient engagement in research. We actually have a couple of questions already coming in the chat. So I'll read those out, and perhaps Samuel, as well as Holly and Chris, feel free to chime in and provide your commentary, and of course others as well. So the first question is from Clayton. So do you think that a focus on engaging dominant voices or popular individuals from a patient partner community might also be an ethical issue?
Can I jump in and say something there? Would that be okay? So Sam, thanks so much. I have all kinds of notes here, and I'm on the panel and I already had questions, but I have new ones. So I would just say this, so Clayton's question is related to my thoughts about the point you made about representation. And I'd love to hear from other folks who are recruiting patient partners and partners who have been recruited. I often struggle with having that diversity of voices, reaching out to relevant communities. Often in our research, certainly in my experience, and I wonder if others have the same, when I advertise a patient partner opportunity, most of the time, I will hear back from white, well-educated, pretty well-to-do folks, middle income, higher, retired. That's often who will come back. Not all the time, but often. So and then when you try to reach out to particular communities, I struggle with, what if they don't get back to me? How often is too much for me to reach out to, let's say, an Indigenous group, for example, or a person that I may know who works with Indigenous communities, so I can try to build that relationship and let them know about so I struggle with, yes, I want to have diverse voices, diverse representation. To getting to Clayton's point, I actually do think it's an ethical issue, Clayton. Yes, when we have the same people who volunteer all the time, as wonderful as they are, don't get me wrong, but I wonder if you have that dominant voice, what kind of representation do you have? So I do think we need to think about that carefully. And I struggle with the balance between getting a good representation, diverse voices, diverse communities, and lived experiences. That's what we want, obviously. How we get that without bordering on harassment of how often do I reach out to said community. So I do think that issue of representation, diverse voices, who those patient partners are, I think that's really, really important. I don't have all the answers for it, but I do think we need to be really, what's the word, diligent, and really work hard. It's a lot of work to really identify those diverse voices. That's certainly been my experience. I'm quite happy to hear from others on that. I really struggle with it. I'm aware of it, but I struggle with it.
Yeah, so I'll just jump in there to say thank you very much, Clayton. And yes, this is going to be actually perhaps one of the biggest ethical issues, because sometimes it's the easy way out. So when we're having research, okay, we know this person, the popular person, just ask, and then we get the research going. It makes everything easier because you get quick response, and then we get on to the next phase. But I think part of the bigger challenge, perhaps for the research community, is actually to do a research on how to build their own relationships with the relevant communities. Is to go out there and perhaps go out of our comfort zone. We are probably even more now with everything being virtual. Just go online, post the announcement, and we hope that everybody hears it. But not everything happens online, because there are a lot of other things that happen offline. And I think it's taking that extra step and going offline and actually approaching the communities and begin to build a relationship and gain the trust. And I think this is what the whole ethics guidance about, is building that trust, finding ways to build the trust. And once you build the trust, then you will know who is actually the popular figure within the community, not the popular figure that we know outside of the community, but the popular figure within the community that we are intending to get. And once we have the popular figure within the community that we are trying to engage, then we'll be able to get the voices, the real voices of the community. So that person could be popular within their community, they may not be popular outside of the community, and we may not know them unless we engage in that relationship building. And I think that is where the ethics, so the relationship building is going to be a key ethics element in the process. And I don't think many people think it's an important ethical aspect, but it is. And it's only when you build the relationship, that trust, that we can get the trust to begin to come up. And then when the researchers are trusted enough, that is when the communities allow them access to the important voices within their communities. And I think also understanding how that works, and that can work very differently for different communities. For example, you could go to one indigenous community and their process of getting that trust and getting access may be different from another community. And so at each point in time, we may have to learn and unlearn. And when we're dealing with some other racial groups, for example, each racial group may have their own dynamic. And the process, we have to be willing to go through that process of building that relationship and learning what is important and how to get in.
And it's a tough thing sometimes because the structure of academia, I don't want to take us right off this topic because there are a couple of comments in here I want to acknowledge in the chat that are so great points. But the structure of academia, I think sometimes is difficult to find the time that it takes to build that trust, because that does not happen overnight, definitely not. So I struggle sometimes with all of the other commitments that a researcher may have. And by the way, that is my perspective, everyone. Sorry, coming to you today more as a researcher. And some of the questions I hear from fellow students and colleagues who are also trying to get this right. I just want to, so Sam, yeah, great points. And a couple here in the chat as well related to this about the, targeted sort of adverts, really specifying who you're looking for. And community brokers, Joni, yeah, that's a great idea. People who live in and are part of the community and can sort of help get you into that community, because that's important. If you don't have any relationships of your own in that community, I think you do need that kind of introduction almost into that community. I actually think that's a really good idea. And we've had some success. I was saying to Teresa there in the chat, we've recently recruited for a public interest group on cancer research. One of our leaders here, Savas, and we really were very targeted in our advertisements. We were very honest, getting back to your point about honesty, Sam, so important. We honestly said in our advert, we want representation from all over this province. We especially want to hear from people from Labrador, because they're often left out, in a lot of my work anyway. We want to hear from young and old. We want to hear from all genders. We want to hear from all ethnicities. Please consider applying. We were very honest about that. And we actually did get a good response. And that's the first time that we had been really specific and honest in our advert. So that did work a little bit for sure. Julia, sorry, I don't want to take us off. Maybe you're trying to look at the chat as well. So I'll defer back to you.
No worries at all. I think we could spend a number of hours discussing this, but we do want to get to as many questions and comments as we can. I'll just go back to Katie's question a few minutes ago. Wondering if there's any practical suggestions on how to balance power dynamics and imbalances when talking about a research team, I assume between researchers, patient partners. Not sure if anyone wants to jump in on that.
That is an excellent question. So I just want to say something really quick and really simplistic, but I have found it really helps. So I tell people immediately when we're sitting around a table with patient partners, I do this with students all the time as well. I simply say, please call me Holly. I'm Holly, call me Holly. I use my first name. I don't use I'm Dr. Etchegary. I'm a professor of blah, blah, blah. I simply say to them, I'm Holly. I have an interest in this topic. Here's why. I will often share personal details about myself as well. Not everyone is comfortable with that, but I'm a very open person. So and those of you on the line, some of you will know that about me and will likely now grin. So yeah, I'm quite honest about that. So for example, we did in a breast cancer project, I said to everyone sitting around the table, including the oncologist, the nurse, and the patient partner, my mom had breast cancer the year I graduated high school. That's why this matters to me. And I find that alone, sharing a little bit of info, here's why I have an interest, here's my first name, please call me by that, immediately just it just seems to be a really informal sort of tone then to the meeting, and people can feel free to speak. So that's one very simple tip I would offer.
I have a comment on that, and I'm Chris Carter, and I sit on a patient advisory committee, so I'm a patient advisor, and I have been involved in different research projects. So in terms of practical suggestions, I think communication, once you're on, say, once you get on to a project and you're a patient partner, it's avoiding tokenism so that you are regarded as a key part of that team. And while you may not be a doctor or a professional researcher, your viewpoint matters and is respected. And I think part of what the team needs to do is like talk about the roles everyone has, that so that the patient partner is included as a real partner. Also communicate, make sure that the patient advisor or patient partner on that team is not left out of meetings because somebody forgot to include them. That happens. Or they're not given the minutes because somebody forgot to include them, or decisions are made offline that they hear about probably a lot later than they should have, decisions made without their involvement. So for the researcher, it really involves, if you're going to involve the patient partner, really involves a commitment to make them a true partner. And those are just some examples I would throw out there. I don't know if there's anybody else on the call who might have some thoughts on that or just might like to jump in.
Yes, so I'll just to quickly note on that, if you look at the document, there's a section on the power dynamics and imbalances, and I think that provides some kind of direction on how to navigate how to ethically navigate this kind of situation in the research partnership.
So I believe Holly actually provided a link to the guidelines in the chat as well. Thanks for that, Holly. So you can refer to that. Stuart bring up an interesting point as well about the role of funders. So he says, for example, are the reviewers who review patient-oriented research or research which engages patients themselves conversant with these challenges or broader issues in patient engagement? So are they aware and understanding of these issues? What are the ethical obligations for the funder, such as CIHR? I think that's a very good question.
Yeah, it's an excellent question, Stuart. Hi, Stuart. Nice to see you, by the way. Stuart and I did some work together in Ottawa in the interest of my telling you how honest I am and open. There you go. So yeah, no, it's an excellent question. I don't know, actually, Stuart. I don't know if Sam will know what what kind of sort of training or knowledge reviewers would have of patient engagement. But I'm just getting at your other comment there as well, talking about, funding outside of grant deadlines to support all of this, to get at that relationship building. I agree with you. I think all of it really takes time. And I don't think there's a lot of infrastructure or support to support it on the ground every day, as well as we're all trying to do. The support units are an obvious example, certainly, of that. And so it's a place to go. But in terms of the reviewers, I think we're getting better. My guess would be just from my own reviews of grants, I would say, when I get back reviews, I actually see today compared to 5 years ago, much better knowledge. The way reviewers talk about the patient engagement plan I have put in my grant is much more nuanced. They do seem to understand it. So I think we're getting better. But Sam, I don't know if you're aware of any particular sort of, knowledge that people who are reviewing those grants would have. I don't know if that's your area in CIHR or not.
So I would just say for sure that at least on the ethical part and in terms of getting that engaged partnership, there has been some recent call from CIHR where CIHR is actually granting kind of specified funding that allow, for example, indigenous communities to be part of the investigators in the research. So in a way, they are part of those who are leading the research, rather than the traditional process of only simply having the researchers doing the research. So there is those funding that are coming out that effectively engage. So which ensures that it begins to put the process of partnership on the track. And in doing so, beginning to address from the top some of the ethical challenges that we may find. So when we have the patient partner somewhere in the middle, as perhaps as also co-investigator in the research, then that actually effectively pulls up the partnership process to a level that can begin to even balance, talking about the power balance and imbalances that we're looking at. So in doing that, it kind of begins to address, in a way, from a funder perspective, the ethical challenges that the whole partnership process is going through. But also, to put it on the other side, the patient partnership engagement in research is still an emerging space in the research process. So not all the answers are there, not all the trainings are there, if any, and it's part of the reason why we have this guidance document as one of the few things available there that we can have a reference point from where to begin. And as we go down the line, there could be more materials to refer to. There could be more kind of workshops or more training to refer to. Perhaps this particular workshop that we're on right now can be part of the whole process that advances these ethical challenges that we have.
Hello, this is Austin, and I have a lot of experience being a patient partner, and I think it's good. I've been involved with several research projects over the past several years as a patient partner, but I'll give you an example of one of the research projects I worked on. This was out of Western Canada. It was a research using, the research was basically introducing a new way of matching organs. So I was introducing a new matching type of thing. Anyway, I won't go into details about that, but I tell you what, the way that it started was the researcher recruited 14 patients from across Canada. Nobody else, just 14 patients that were affected by this particular subject that they were researching. So there was just patients. Now, in the background, there was another group, a planning group, that would take the feedback from the patient group, I would call them, the advisory group, the patient advisory group, just full of patients and a researcher. Then, after several meetings with patients and the researcher, a group was formed and they selected the patients from the 14 patient advisory group. Like, not the group, I'm just saying, for this particular research. So all of those patient partners, 3 of them were picked out, and then they were recruited, not recruited, that's not the right word, but they were participating in the research. It took 2 years to do the research. Basically, it was educating people and introducing them to a new way of thinking, but it was the booklet was for like a deliberate dialogue. So you take a focus group that does have, we say, a group that represents everybody, but that would be impossible. But a group that you think that would don't have an interest in the research project, and they were just give it to them and get their feedback. You know, not people that are affected by the research, but a public group. And the patient partners were part of the whole research, and it's still ongoing today, and the patient partners are still involved. So that to me was a good experience, because during the patient advisory group, most of the patients get educated, not so much through reading papers or so much like that, but listening to each other, listening to different points of view. Like you would have people that are donors, you would have caregivers, you would have people that gave, people who recipients, all different assets of people in different parts of the nation would have their say. Of course, I was the only one there from Eastern Newfoundland, as far as I know. But
Thanks, Austin.
But
Yeah,
anyway,
listen.
I'm sorry
Yeah.
that's just my input right now.
Yeah, listen, sorry, I didn't mean to interrupt you. I wanted to say thanks for sharing that. That sounds like an interesting project. And it's funny, given our discussion just now about diverse voices and representation, I was thinking as you were talking, oh, okay, all across Canada, different perspectives, like you say, donor, caregiver, patient, etc. I think that's important. So that is maybe a useful example of the value of those different voices, right? So thanks for sharing that. Yeah, great. Excellent.
Thanks, Austin. Chris, were you about to say something as well?
Yeah, I was just going to say that, as a patient partner on a research project, we've had discussions about this, whether I'm representing a community or whether I'm representing the health issue, from my perspective. So if you're on there to research a health issue, whether it be diabetes or whatever, I'm a caregiver for someone with diabetes, for example, then I don't feel I'm representing the illness or my experience, but I don't feel I'm representing a community, So I don't know. So when we talk about bringing in diverse communities and everything and different perspectives, I see that, but is that a responsibility for, the patient advisor? Certainly we want to get participants from those communities onto our research so we can get a lot of the data we're missing. But I do think that, and I think that you just said it, I don't know who was just speaking, but you did mention that ultimately we represent ourselves, our experience with the illness, and try to contribute from that standpoint. That's just a point. That's just a thought.
No, Chris, I think that's an excellent point. And I know we're getting at time, but I just want to acknowledge Karen has a great point in the chat related to what you just said. And she's saying, maybe we need to build the role of the patient or the partner, the family member, build that into, is it their responsibility to represent a diverse community? If it is, then maybe we need to be building that into our role descriptions. I never thought about that before. That's a great point. So we could, if we have a project and we do want a community's voice representing a particular community, maybe we could build that directly into a role description, as opposed to, we want to hear from you because you have lived experience of A, B, C, D, not necessarily representing an entire community. Yeah, I take your point. And you know what, Chris? I don't recruit an oncologist to my team or a nurse and expect them to represent all nurses and all oncologists, for example. So why would I expect that of a patient partner? So yeah, good point. Good point.
And we define patient partner as a person with lived experience or caregiver. So sometimes, I think, I know what we're talking about, generally speaking, like an overhead umbrella, but when we actually get to the specifics of it, there's a bit of melt,
Yeah. Agree.
But I agree with you, Chris, that you can only offer your perspective. It goes for everybody. It doesn't matter what the subject is, because we're all subjective in a certain way. That's the way I feel anyway, because my experience is that when people look at me and the people look at anybody, they make a judgment right away as soon as they look at your face. That's just human nature. That's the way I see it. But I agree that if you live the experience, then you have a lot to offer to any research. And it's definitely based on living experience, right? Like yourself, you're a caregiver. I know caregivers, and I can tell you that as a patient partner, I'm probably taking it to the extreme, because I'm involved in many peer support groups and I talk to a lot of patients. But the one thing that's missing in all the peer support groups is they're all patients, right? The peer support groups are just patients. So it's like getting together at a coffee shop and having a big coffee shop chat. But, you know, in research is different. That's the way I see it.
Yeah, yeah, thank you. Yeah, I see what you're saying.
Yeah.
Thanks, Austin, and thanks, Chris. We do have, I know we're over time a few minutes. I do just see one other question in the chat that I'd love to get to before we finish, from Renee. So Renee says her background is in discourse analysis, and she was wondering if there has been an ongoing discussion on the use of the term patient. And this is something that, you know, when I came into the patient engagement space, I had the same question in my mind. She says, thanks for the information regarding the definition of patient. Have there been discussions regarding the word patient? Is it the most appropriate to use at this point in time? Are there any ethical considerations with using this terminology? So thanks for that question, Renee.
Yeah. I'll say something really quick. I'm happy to, Sam, if you have thoughts on the ethical considerations, but I will answer the question quickly with yes. There have been many discussions. Renee, I've been a part of the National Working Group on Patient Engagement since 2015. And when that group first started, when we started to talk about patient-oriented research in Canada, all of the patient engagement folks at each of the support units began to get together. And that question, do we need to use the word patient? I don't like the word patient. Maybe we should use a different word. Now, CIHR as the funder, that was the word they were using. That's why we use the word, by the way, with that definition, recognizing it's broader. It also includes informal, you know, caregivers, family, friends. But I remember the patient engagement leads across the country having 2-hour meetings every month. And I bet for the first year, that's what our meetings were about. Can we use a different language? What should we use? Right now, I'm in discussions with a patient partner from Ontario on a national council who says to me, Holly, I want to be called a lived experience advisor. And the terms of reference for the group is Patient Partnership Council. So we're in the middle of talking with her. So I've suggested maybe what I'll bring back to the group is a patient partner on this research project may mean one thing, and a lived experience advisor may mean something slightly different. So the quick answer is, yeah, there certainly are discussions about it. And I'm happy to follow up with me on email. I'll let you know how that discussion goes with the other patient council. Sam, I don't know about you, and any ethical, do you think, considerations to using the term patient or not?
Yeah, so just going with your point, I'm not sure this is going to be a discussion that will end anytime soon in terms of it's about the definition of terms. And whether it's appropriate or not appropriate, or whether people like it or people don't like it. But I think it's perhaps the fact that we need an identifier that can help us to describe what we mean. And I don't think the point of the patient is about diminishing the role of the patient representative, but rather about trying to define terms, trying to find a term that can help us capture what we mean. And I think that's the point where the guidance document, for example, tries to define from the beginning, this is what we mean when we say patient here. Because patient can mean anything, different things in different contexts. But when we're talking about in the context of the research partnership, then this is what we mean. And I think that it's probably drawing from that large bunch of conversation to say, okay, well, we have to tell everybody else, this is what we mean in this context when we talk about patient. And I think part of the ethical challenge maybe would be about the power dynamics and imbalances, because there's that traditional part of the researcher and subject could creep into that collaborative partnership that we are trying to create. But it will also always help when at the beginning of every time we are making this engagement, we have to define at each point. So that way it reinforces, but also reemphasizes that this is what we mean. It doesn't mean that other kind of patient that we have always encountered in the traditional mode of doing research. But in this space, we are looking about that patient, the term, only as term, to capture this group of people who are now collaborative partners, who will be co-creating the research rather than being studied in the research.
I'm sorry, I have to leave. Thank you for everything.
Excellent. Thanks, Austin.
Thank you,
Okay,
Austin.
bye-bye.
Take
Thank
care.
you.
Take care.
I'm gonna pick up my grandson.
Drive safe.
Bye-bye.
So I know we're almost 10 minutes over time. I don't know, does anyone have any final comments, questions? Of course, we're, speaking on behalf of all the panelists, that we are available via email if you do kind of think of something you'd like to ask after the presentation. But before we close out, is there any final commentary from anyone?
I would also just say thanks to everyone for the engagement. Excellent. Really appreciate it. Yeah.
Yeah,
Awesome.
thank you. I echo that, Holly. I know we could have spent a number of hours talking about this. It's such a huge topic. I'm sure that, we will be hosting another session at some point in the future related to this topic, because there is so much to discuss. I'll put my email there in the chat, juliabert@mon.ca. If anyone has any questions or further thoughts, comments, feel free to email me and I can get you in touch with the right people. So again, thank you to everyone for participating. And of course, thank you to our panelists, Chris, Holly, Samuel, for joining and providing your valuable perspectives. Just a quick note that NL Support does have a training program. So we do have some upcoming webinars as well. I did want to mention that in February and March, we are hosting a research design series where we will be having a variety of weekly sessions on various quantitative and qualitative research methods topics. So our quantitative sessions will be held in February and our qualitative sessions will be held in March. So you can go to the NL Support website, and I'll put the link there in the chat to register for these upcoming sessions. We do have a free training program as well. So if you are interested in receiving a letter of completion, you just need to attend 6 sessions in a 2-year period and you'll get a letter of completion. As I said, thank you again, everyone, for attending the session. Thanks to Holly and Samuel and Chris for your valuable perspectives. The recording for this session will be up on our website. So if you do want to refer back to it, or if you know other people that maybe couldn't attend, feel free to share that link with them. So with that, I'll let you all go. And again, thanks everyone. Have a wonderful afternoon.
Thanks everyone. And thank you, Julia, for your great hosting abilities as always.
I didn't do much.
Thank you.
Bye
Thanks,
everyone.
Have a good day.